City Club of Portland is where civic-minded people have come together to find solutions to our region's biggest challenges. Today, we're a diverse network of people who are eager to learn, connect, and share ideas for a better Oregon. Thank you for joining us at the Sentinel Hotel in downtown Portland, where thousands of people are joining us online, on the radio, and on TV. Live viewers are watching on KGW's website, Facebook feed, and news app. Our radio audience is listening via X-Ray FM stations 107.1 FM and 91.1 FM, and TV viewers will watch today's program via Open Signal's community media television stations. We're incredibly grateful for the support of our media partners in bringing City Club forums to our community. In addition to City Club's valued media partners, our sponsors, volunteers, and staff enable us to put on Oregon's best civic programs week after week. I'd especially like to recognize the Pride Foundation and Quest Center for Integrative Health for sponsoring today's forum. Please join me in showing our appreciation. In Oregon and across the country, many LGBTQ people are not getting the health care they need. An LGBTQ person is more likely to be uninsured than their straight neighbors, and transgender people in particular often face ignorance or prejudice when they step into a doctor's office or health clinic. How do we educate health providers and change institutional policies to ensure that everyone, regardless of gender identity or sexual orientation, has access to high-quality health care? Here to help us answer these questions and more are Angela Carter, a primary care provider and co-director of the EQUI Institute, serving a large and primarily transgender and queer patient base; Danielle Walsh, a licensed professional counselor who provides mental health therapy at PRISM Health, a program of Cascade AIDS Project; ERIN Waters, a community health navigator for KAISER PERMANENTE Northwest; and NEOLA Young, coordinator for the Gender and Sexual Health Program at Legacy Health. Moderating our discussion today is Lisa Watson, Deputy Director of Our House of Portland, an organization dedicated to providing healthcare and other vital services to low-income people living with HIV. Please join me in welcoming our guests.
Thank you for being here today, and thank you, Colin, for the introduction. Thank you also to all of our panelists. I'm excited to hear your insights today and your perspectives on this important topic, but I want to take a moment to ground us in some shared vocabulary before we get started. In particular, I want to break up the LGBTQIA2 acronym that we hear a lot, but that some people may not be totally familiar with. So if you'll bear with us a moment, I'd like to explain that. The L, G, and B, which stand for lesbian, gay, and bisexual, are the letters that people are probably most familiar with. They refer to sexual or romantic orientations. The T stands for transgender, which describes people whose gender identity doesn't align with the sex a doctor assigned them at birth. This can include trans men, trans women, non-binary people, and a range of other gender fluid and gender diverse experiences. If your gender identity and sex assigned at birth align, then you are referred to as cisgender. The Q in LGBTQ can refer to questioning, people who are learning about their gender and sexuality, or to queer. People, today, it has a long history as a racial slur that's been used against LGBT people, but today it is being reclaimed and used by many in the community as an umbrella term for people who aren't straight and or cisgender. The I stands for intersex, which describes people who have a combination of genes, hormones, or sex organs that don't fit into the two typical patterns of male and female. The A for asexual or aromantic refers to people who have no or little sexual or romantic interest. And finally, the two refers to two-spirit, which is a term coming out of tribal communities and refers to a specific indigenous identity embodying two genders. You don't need to be an expert in all of the jargon to engage with issues impacting LGBTQ communities, but I just wanted to give everyone a primer. So if you hear us say LGBTQ health outcomes or refer to queer and trans leaders, you have some background on what we're referring to. With that being said, thank you for indulging me. I wanted to start our conversation with sort of a look at the big picture. What are we talking about when we refer to queer and trans health? And what are the most pressing health issues facing LGBTQ communities today? Erin, maybe you could get us started and give us a little background on where we are.
Sure. One of the biggest challenges when it comes to supporting transgender and gender nonconforming individuals is access. And when we talk about access, one of the things we're talking about are things like social determinants of health. How can you actually get to the exam room in a way that is full, in a way that is representative of your actual health needs, and without necessarily feeling stuck in that power dynamic between you and a doctor? And so one of the challenges that we struggle with continually is training. There isn't a whole lot of training that's done before someone gets out into the world trying to do or offer some of this medicine. And while that's changing, and there are some institutions who offer it now, one of the things we're having to do is catch folks up. You've got providers who've been doing this for 20 or 30 years, and so what they need is an opportunity to kind of fill that gap. And so we then need people who can train. And so we are in a unique place in the country where we have a lot of folks who can do that, but not necessarily everywhere. So it's still a challenge overall.
And then Angela and Nola, you have both in conversations talked about the need to move the conversation beyond just hormones and surgery. What are some of the larger or more upstream issues that we should keep in mind when we're talking about health concerns in the LGBTQ community?
This is
Either one.
where we decide. I think one of the things that we also look at, when we talk about transgender people, we talk so often, I think our minds go to hormone therapy, surgical care, what we call gender affirming care. But there's also a lot of other things going on, right? I am a trans person, and that's like 2% of my health care that is actually going on for me. But there are other things in our community that we look at that affect our health care. Do you have access to food regularly? Do you have access to housing regularly? Do you have a social group? Do you have people? Do you have friends? Maybe not family. It's like we know the common story in our LGBTQ communities of how many of us have lost our families, have created new families. If you don't have that social support or are very isolated, that can really do a lot to both your mental health and your physical health. That creates those things. I feel like what Erin's talking about with social determinants of like the loss of those things or not having access are incredibly impactful what your healthcare looks like.
Would you like to add anything?
Sure. I would say that in accessing care also, so transgender people face a lot of discrimination from all aspects of life, and the impacts of trauma on mental health are extensive. PTSD, bipolar as some influence from the lived experience as well. I see attention deficit issues, executive function issues, major depression, anxiety. There's a lot to face dealing with a constant onslaught of discrimination. So I think that having access to trauma-informed and culturally relevant mental health care is incredibly important.
And can you talk a little bit about ways to reduce the stigma that might be attached to that mental health, creating spaces that feel safe and that sort of thing?
Well, so, creating spaces that are safe can come from many directions. In a medical office, you can have markers that you have an awareness of the community, put up posters that celebrate people in community, have flyers out talking to people about, what the impacts of capitalism, of trauma, of all of these things on their mental health, on their physical health. Inform people, let them know that you understand where they're coming from, what they're experiencing. Go to trauma-informed care workshops. Trauma-informed care is incredibly crucial for the trans community. There's a lot of fear that a lot of trans folks have about going to medical providers because they may have faced discrimination in the medical setting previously, because they may have heard that they would face discrimination. So there's a lot of fear and anxiety about just going to see a doctor. And so finding a way in your visit to just hold the space and take a moment and recognize that person in front of you as a human and validate their experience. That's, I think, a very important first step.
Thank you. Looking at this another way, are there secondary or tertiary benefits to meeting the health needs of LGBTQ people? We addressed this a little bit But for instance, Danielle, if we can ensure that all LGBTQ people have the access to the mental health and behavioral health services they need, how do you see that impacting the rest of that person's life?
Yeah, absolutely. I think a lot of times when we talk about queer and trans people and mental health, the conversation gravitates towards statistics and pretty depressing statistics at that. So we talk about suicide rates and higher incidence of mental illness and substance abuse. And I think one of the more important things we can be talking about is, the resiliency and the gifts of the queer community. A lot of really well-intentioned energy goes into pointing out disparities in healthcare, and it's absolutely an important conversation to have. But personally, one of the things that I do as a practitioner is try to look at the strengths and the gifts that my clients and patients have to offer. So I think shifting that perspective is really important. I'll say, just giving a little bit of context about the clinic I work in, we're seeing people, PRISM has been around for about 2 years offering primary care services and just recently offering mental health services. But the people we're seeing coming into our office have been out of care a lot of times for 3, 4, 5, 10 years, just because they haven't had a safe, competent place to go to get health care. And it's great to see people coming back into care, and not only coming into care, but utilizing our services extensively. We see that folks are coming in at a higher rate than average for primary care visits. So that's really, really great to see.
That's awesome. Thank you. Of course, LGBTQ communities aren't a monolith. There's a lot of complexity. Are there any subsets of queer or trans communities that any of you would like to share experiences that you think particularly have challenging health outcomes that we haven't spoken about so far?
So I can speak to that one. So like NEOLA said, being trans is only a percentage of someone's overall health care. And so when we're talking about these various identities, we need to look at what other things people are bringing to the table. So when we're talking about those social determinants of health, we know that communities of color have a tendency to struggle with more housing, struggle with food access. And so that increased struggle makes it much harder for someone to not only show up to healthcare, but to actually get those healthcare outcomes sorted. Talking about myself, I'm a transgender woman, that's part of my healthcare, but I'm also a woman of color. And we tend to have the lowest healthcare outcomes of every group. And so when we are talking about how we support folks, just like Dr. Carter was saying, we need to make sure that when we're creating these affirming spaces, we're taking into account all the different layers of someone's identity, which may be a factor in the exam room.
Anyone else want to add anything to that?
I think, this is where we have to really be talking about working with queer and trans people of color. And then there's other things that we talk about, right? Different abilities, how your body works. Young people, youth. I don't know how many, my background is in so much youth work, how many young people are like, why don't people believe me that I can know what my sexuality or my gender is, right? It's about that belief or the value of who you are and the wholeness of who you are. We may be going to someone because, one of the leading things I ask about my own healthcare is, how will someone react to me because of my gender presentation? If I ask them to use my pronouns, is it gonna be a thing? Like, is it gonna be me teaching them, or is it gonna be them just being like, I'm not going to do that? And then we have a real problem because I'm there for care and I'm caretaking my healthcare provider, right? Our healthcare should be going in for healing, not to take care of. I really love the people who take care of me, and also, that's not my job. My job is to be a patient, right? My job, I do take care. I do take care of a lot of our providers in that I'm helping them to learn the gaps, challenging them on things like bias. Like, somebody can say, no, I treat all of my patients the same. That's the thing I hear all the time. Here's the thing, not all of our patients are the same. So it's not, I think, I read stuff all the time and bug people all the time about things. When I see the word regardless of, when I see something that's like, we treat everyone regardless of race, ethnicity, ability, language, income, etc., I actually want our care to be with regard to, not as a barrier, but as the information that you may need to give better, more informed care to people.
so that clinician can honor each of those identities for that person.
Absolutely,
Right?
absolutely. Yeah.
Thank you. In addition to a lot of those ongoing realities for folks, there are some distinct or acute challenges surfacing at the federal level. Just last month, the Federal Department of Health and Human Services proposed rolling back non-discrimination protections for transgender people, which could affect people's ability to secure both health insurance and health services themselves. Nola, I'm wondering if you could speak to how you see those changes like this impacting people here in Oregon and what can be done to mitigate the impact of those. And anyone else is welcome to chime in as well.
I feel concerned that I'm going to say this on the record, but I'm going to say it on the record. As we know, there's a lot of state to Oregon, right? We have a lot of gaps, and also, I think when I keep seeing these headlines, I'm not fretting. I'm not, I feel worried, but it's in the back of my mind, and I think it's because we have a fierce group of people who for many, many years have been digging in. Many folks in this room, many people who have passed on before us, people who have made the way that I have always done work, and I've done a lot of policy work, so I've shaped some of the things that have affected the things we're talking about, and also my jam is I want to get in front of somebody to say, regardless of what the law says, can you go above that? Is there a way for you to go outside of your value systems? Is there a way to ask questions of your value systems? I absolutely think, yes, we will have providers, we will have insurers who start asking, can we turn people away? Can we say no? Most of our insurance plans that are available in the state of Oregon have allowance for transition-related care, and that is because of the hard work and advocacy of people. We had lots of policy things and changes to be made, but so much of it was getting in front of somebody to say, here's the thing, here's an actuarial analysis, not actually going to cost you a lot of money to do this. 2, this is really just about bias. And they're like, no, it's not. And we're like, cool, prove it to us, right? Put it in there, make it possible. And also we have a lot of people who live in Oregon who have insurance policies that are bought and sold outside of the state. Those are the folks I'm worried about. Those are the folks, like the people who have insurances that they work for a global company. The laws in Oregon don't necessarily apply the same way. And that's where I feel concerned of that suddenly if they have that access to something, it'll get stripped away. The other things that I feel concerned about are folks who are more rural communities. I love the stories I get though all the time. We call people incessantly and are like, are you taking patients? Are you taking patients? Can I just send you one patient, right? It's like, can we get somebody to you? Because I believe in getting healthcare in your backyard. I hope that we can turn around this pattern of somebody has to drive from LeGrand to Portland every time they need to get tested for sexually transmitted infections, or every time they just want to talk about, can they start PrEP? Can they start Truvada, for PrEP, for HIV exposure? Can we talk about, do I have to drive 5 hours every time I need to do labs for my hormone management? And that's, my concern is I think less about our Portland metro area and a lot more about our siblings who are outside of our little bubble here.
Does anyone want to add anything to that?
I think this is one of those moments in which we're going to be looking at allies, and we need our allies to become more active, and we need to turn those allies into accomplices. And that sounds a little funny, but for example, when I first got to Oregon, I tried to change my driver's license, and the DMV here had a list of approved doctors, and if you didn't get a letter from an approved doctor, they weren't going to change your information. And the day that I went, I had a letter from not an approved doctor. And so instead of turning me away, I had someone wait until their supervisor finished walking by, and then said, you know what, we're just going to do this for you. And they made it work for me. And so that was actually way easier for me to continue to get a job, something that fit my presentation. And so that moment in which an ally becomes an accomplice is stepping outside of some of your moral space. We're not saying do something illegal. What we're saying is we need you to take a moment and understand not just how you want to be treated, but understand that there is equity that needs to be found here. There is a historical lack of positive treatment, of equality, and it's on you personally in this moment when you see this person drowning, hold out your hand and find a way to pull them up with you. I think that's how we're going to be dealing with other issues as we move forward at that level as well.
Thank you. Thank you. Let's move on. I'm going to ask each of you to share a 1 or 2 minute story of how you got here. What led you to become a practitioner focused on LGBTQ people? Or what led you to say, you know, I want to make healthcare better for queer and trans people? Let's start with you, Angie.
I have been doing work in serving the queer and trans community since I was 16. I started work at the Lavender Youth Recreation and Information Center in San Francisco, and the training at that center advised me that my community was facing so much trauma, so much discrimination, so much pain, and I had to do something about it. So my work has been moving towards, over the years, health equity for queer and trans folks. I started the EQUI Institute, which is our clinic in the Q Center, back in 2014. We started it. We got our 501c3 this April, or March rather, and we're starting to move forward. And so it's the people in my community. It's just so much beauty, and I love the work that I do.
Thank you. Danielle?
Yeah, so I haven't worked with the queer community my entire career, but I am a queer woman and I've been out for about 20 years now. I first decided to become a mental health counselor because I was doing some pretty difficult work with trauma survivors, and just realized that if I'm gonna be helping people the way I feel called to help people, I need to have some skills specifically around taking care of myself. So that kind of led to my decision to go back to school to be a counselor. But I will say, I feel like my career's kind of come full circle, coming back to work with the queer community. I know myself as a queer woman, I've had experiences where I've gone into doctor's offices and you know, had conversations with physicians trying to prescribe birth control for me, and having to explain why I didn't need that for, you know, 30 minutes before someone would listen to me, and even then not having people listen to me. So the fact that I'm able to work in a queer clinic where hopefully people aren't having those kind of assumptions made about their identity is really important and life-giving to me. So I'm grateful to be doing the work I am now.
Great, thanks, Danielle. How about you, Nola?
I grew up in Mississippi, and all the things you probably think about Mississippi are probably true. And also, Mississippi and Oregon have a whole lot more in common than you think, so that's my challenge. Please go visit, it's beautiful. There's a new civil rights museum that opened that is an incredible experience, so that's my end of my spiel. But I grew up in Mississippi where the access to services is so low. And I remember the first time it was, I'm going to talk about pap smears for a minute, FYI. Also, if you have a cervix, please think about going to get that checked. I will help you find a provider if you would like to do that, because cervical cancer screenings are incredibly low in the LGBTQ community, and I would like for us to be alive. That's my spiel. I don't think I'm supposed to do that, but we're in a healthcare forum. Please get your cervix checked. But it was like 21, 22 before I had my first pap smear, and I remember being like, I don't know, I feel so uncomfortable. And my mom was like, go to my doctor, and you know, he had been like an OB-GYN for like 50 years or something, and I was like, no, I don't actually want that to happen. So I started looking around, asking around, and I remember somebody said, oh, I go to this doctor, and she's amazing. She's gay, she's a lesbian, and she's the cousin of this person, or maybe a friend. And then I later found out it was literally just they had the same last name. And there was a rumor in our little tiny LGBTQ community that this one doctor would give you like affirming care and could do the pap smear. And I was like, the work I had to do, it took me the better part of a year to land on that one person, and then I got mad. And that's how I got into this work. It was truly selfish. And I was like, wow, we have all been going to this one doctor thinking that she's a really cool like lesbian cousin of somebody else in community, when really she just was a really good doctor.
That's awesome. I think a lot of activists end up where they are in very similar ways, for sure. All right, go ahead, Erin.
My story is a little bit similar to NOLA. Instead of Mississippi, I came from Georgia, and everything you hear about on the news from Georgia is so true. I was actually kicked out of multiple doctors' offices and mental health provider offices who said things like, "We don't treat people like you." And in Georgia, as in many other places, I had to figure out what that reason was. Like, is it related to my transness or something else? And I had to get out of Georgia. I did not feel safe enough to transition there. So I moved to Oregon, and I discovered that, like Nola said, it's not that much different than Georgia in some ways. And as I was working at a federally qualified health center, an FQHC, I had someone who was doing a lot of work with the trans community. And we sat down and we had a conversation, and I kind of called him to the mat, and I was like, what's happening with communities of color? What's happening with folks who have disabilities? What are we doing for the extra marginalized people in our community? And he just kind of shrugged and was like, we're doing our best. And that was not enough for me. It was kind of in that moment I decided I was going to continue moving forward. I was going to find ways to not just bridge gaps between the LGBTQ community and the regular cis hetero white community. I wanted to work with communities of color as well because there are gaps there too. And so until we can find a way to get everyone on board, well then I'm just going to lift every ship that I can until they all come up with me.
I love that. Thank you all for sharing a little bit of your story. For our radio audience, this is City Club of Portland's Friday Forum. I'm Lisa Watson, Deputy Director at Our House of Portland, and I'm here today with Angela Carter, Co-Director at the EQUI Institute, Danielle Walsh, a professional licensed counselor with PRISM Health, ERIN Waters, Community Health Navigator at KAISER Permanente Northwest, and NOLA Young from the Gender and Sexual Health Program at Legacy Health. We've been talking about some of the big picture issues and opportunities in LGBTQ healthcare. So if we could dig a little deeper into the healthcare issue more, NOLA and ERIN, the two of you work for huge healthcare institutions. What is that like to be one person or on probably a very small team trying to move such a massive system? ERIN, would you like to start?
Sure. My team's a little bit larger than NOLA's. And so it's pretty significantly challenging. There are definitely days in which you realize, okay, we're gonna walk up the mountain and it feels like the first step. And then you get to what feels like the top and you realize, oh no, this is a whole nother mountain we have to climb. I've been fortunate in that I have a really strong physician and social worker who have done they laid a lot of the groundwork within our system to get started. And so when I showed up, I just had to keep rocking the boat. And the way I feel about it is I'll rock the boat, and if you fall out, that's your fault. You are welcome to swim until you can get back in the boat. And sometimes that's a little bit frustrating for folks. I mean, I say things in meetings about folks who have Medicaid and folks who are below the poverty line and folks who are struggling to keep access to care. And it's a little uncomfortable. But those are the conversations that are actually going to change healthcare, and those are the conversations that actually change our leadership. There's sometimes a gap. You'll have a lot of leadership support at the top because it looks really good. And then you've got people on the front lines who just don't want to hurt anybody and they want to know how to help. And then you've got this whole middle layer of middle management who are like, well, how are we going to do it? What's the implication? What's the rollout process? Is anyone going to get mad? These are questions that we can answer as we move forward. And so sometimes we find that while we have that frontline support, while we have that top-line leadership support, navigating the bureaucracy around it is super hard. I'm fortunate that I'm not one person, but I do a lot in and of myself. And so you just have to come to work with not just your heart, but like your whole self. Like all of your passion has to be there, because those of us doing this work kind of trade a little bit of our sanity so that other folks in our community get to have some back.
Thank you. How about you, NOLA?
Same. I don't know.
Ditto.
Yeah. It is both exhausting and I love puzzles, and this felt like the puzzle was how many layers. Legacy is 8 hospitals across 2 states, geographically, culturally, incredibly different place to place. And the thing that I always come back to, everybody asks me all the time of like, how's it going? What is it like being like, the person to coordinate this? One, I have an amazing team of people. I am really all about hiring in as many queer and trans people to work in healthcare as possible, and that started with the program that I work in. The second is I feel that our program is trusted. And that's a big deal to me as a trans person working in healthcare for a very long time. I think a lot of you know this. The trend for so long in how LGBTQ healthcare was, it didn't exist. And then when people started paying attention, people who were not us were making decisions for us. What I really love about the system that I get to work in is that I feel trusted to move that. I feel trusted, I feel asked. I feel like our team is asked for that, and there's so many layers. Every time we think we've gotten down and be like, great, this is cool, but it's been a work in progress. I'm about to enter into year 3, and before that I was a consultant to Legacy. We began with a community needs assessment to ask our community of patients, what do you want your healthcare to look like? And that was our blueprint, and that blueprint has remained our cornerstone.
I was totally in that focus group, and it was awesome.
Thanks for outing yourself. When I first met ERIN, I was like, how do you look familiar?
It's true.
Yes.
Yes.
And it's because she helped to really direct and gave so much great feedback. It can be a really exhausting thing because there's just so many moving parts to a really large health system. And like I say, we don't have an LGBTQ hospital. We don't have a community hospital for us. And until then, I will be sure that the hospitals that we do have in our backyards will be affirming and welcoming as possible to us. And we have a lot of work to do.
Thank you. Thank you. So it is very different for Angela and Danielle. You have a really different experience in your work. You're both in smaller clinics that are focused specifically on this community. Do you feel insulated from the challenges at all, or do they feel similar to you?
Well, so yes, we are a much smaller organization. We are, with our board and all of our staff, only 15 folks. So that provides us opportunity to rapidly respond and quickly move to respond to the community's needs when something comes up. It does mean that we don't have institutional backing. We don't have maybe the capacity as much as a larger organization does to do some of the bigger projects that take a longer time, but we can respond more quickly and make things happen. I love our institutional culture. It's really beautiful to work with this group of people. Everyone is super passionate. Everyone is super social justice directed, and so it's been pretty lovely. And really, we've tried to make our clinic by and for community. We are the community that we serve, and I think that has a big impact on patient outcomes. They see their community reflected in their healthcare, and they see people who understand where they're coming from, what their life story is, and I think that does make a big difference in how people receive care, are able to receive care and access care.
Thank you. Danielle?
Yeah, I was actually just thinking about this earlier when Nola was so eloquently answering the question about federal policy and how that's affecting folks maybe locally here in Oregon. And just to kind of circle back to that question and look at it at a more micro level, the level that I see in my work, you know, regardless of what happens policy-wise, those things that are happening in Washington at the federal level are really impacting my clients. You know, I see folks coming in with a lot of anxiety and depression. You know, what does it feel like when your government doesn't value you? I can see folks coming in, you know, saying, you know what, I need to hurry up and have surgery because it might not be covered, you know, in 6 months. So, I mean, I think having that more micro lens and just kind of seeing things play out on the ground is just a little bit different than maybe it is working someplace like Kaiser and Legacy, although you guys also certainly see that as well. You know, one of the great gifts of being at some place like PRISM is, you know, I think we can provide really comprehensive care to our clients. I can walk 5 feet down the hallway and talk to someone's primary care provider and consult with them. So I can make sure we're providing the best of physical and mental health together at the same time. And that's an incredible gift that not a lot of mental health providers have. So, yeah.
Yeah, particularly in a larger organization. Yeah. Shifting gears a little bit, when we talk about queer and trans health, what are some of the things that each of you think the average person might misunderstand? Or what are some misconceptions that you think are really important to clear up or combat in this conversation?
So for me, from a very fundamental standpoint, I spent a lot of time explaining to folks that pediatric patients aren't just being put on hormones. There are assessments that have to be done. There are significant things that parents end up having to do beforehand. And we do need to believe children, and we do need to make sure that they are being supported. But we also need to make sure that we are not putting incorrect information out there or holding on to incorrect or misinformation, because it really just makes the problem worse. We are diligently working to find ways to support patients where they are and support healthcare providers where they are, so that we can find that middle ground where patients are getting the care they need without the gatekeeping, without having to be told, well, you're mentally ill enough to need surgery, but you're not mentally ill enough to have a problem, but you're still mentally ill. So like, these are things that we really have to challenge.
I think also a trap we can fall into is doing a lot of backpatting. You know, I'm especially mindful of this Pride Month, you know, coming 50 years from Stonewall. It's easy to look at how far we've come, but speaking as a member of the mental health profession, you know, it was 3 years ago that conversion therapy was legal in Oregon. 3 years ago. That's not the distant past, right? You know, in most of our lifetimes, we can remember a time where homosexuality is classified as a mental illness. But even today, for trans folks I work with, I am having to diagnose them with a mental illness just so they can access life-saving medical care. So yes, we have a lot to celebrate, but we have a long ways to go.
Angie, would you like to add anything?
I think that it's worth mentioning that hormone therapy is really easy to do. That is a misconception I think a lot of people have, that it's going to be super complicated, that it's going to take a lot of time to learn, that it's going to take a lot of time to manage. It really isn't. It's really very simple. I think that it's something that can be easily integrated into anyone's practice with the right care and attention. So yeah, I just would encourage people to learn, because it's worth it. It's worth the energy.
Thank you. Thanks, all of you. What barriers would you say are the biggest ones that still exist today?
Which one? For me, it's a lot of institutional inertia. I mean, I work for a big organization. We know what the changes need to be. We know what direction we need to move, but it's hard to get people to move sometimes. We talk a lot about change management. It's a fantastic and fun buzzword, but it's real. It's a thing that we have to figure out, because we're not just changing people's minds, we're changing people's hearts, we're changing people's practice, we're changing everything about how they do work in some cases. And while this may represent a small portion, being told that one day you may have a trans person who comes into your clinic who might need some kind of help and you might be confused is really intimidating for some people. And so that tends to be one of the biggest challenges that I have to struggle with, is kind of getting people to breathe through it, figure out that this might be new, but while it might be new and it might be rare, it's still normal for someone. This is not an abnormal or a problem thing. It's just the healthcare that this person needs.
Any other major barriers that you see?
I think just community-wide, a couple of things. One, competition. Like competition between clinics, between health systems. It's getting in the way, I think, of saying there's so much change to happen, and it will take all, like so much more than us individually doing it. Because then that creates a whole other barrier of like, if that's the only clinic that you can go to, that one clinic can only see, right, so many people, right? That's a barrier. And I think the other thing is accountability, accountability to the community. No matter where you are in your learning about LGBTQ healthcare, you always have more to learn. Sometimes your patients or your clients, or if you work in a program of some kind, if you work in like a housing program or something, we all have more to learn. It's thinking I've got it figured out and I know what to do can end up doing more harm to our folks. That's a barrier, because if you go in to see a doctor that you're like, I heard that this doctor is really amazing, and then something weird goes sideways, and then you're like, well, then if I can't go to this doctor, who can I go to? And I hear that so many times of where people just get scared off. of taking care of their health care, because there's not the possibility to say, I can be in partnership with the patient who's in front of me. I can be in partnership with the community of patients who are in front of me.
Danielle, anything for you?
Yeah, I am really mindful of stigma. I think as a a mental health practitioner, there's a lot of stigma around mental health, and then on top of that, we're working with a community whose very identities are stigmatized. One of the first things I tell someone who sits down across from me in a therapy room is, you're not in therapy because you're queer or you're trans. You're in therapy because we live in a homophobic, transphobic world. And I think just normalizing that for folks, because it's so true. Kind of the burden of having to face these barriers to just even getting into care really takes a toll on people. And just acknowledging that and recognizing that, I think, is super important.
Any barriers you'd like to add, Angie?
Just the access piece with having enough providers. We just don't have enough providers of any sort, and providers who are accessible to people who are on Medicaid. A lot of folks in the trans community face discrimination at work. They lose their jobs, or they are marginally employed for long periods of time. They have difficulty getting to appointments. They have difficulty getting enough food. It's outside of the office, I think, more than anything. Inside the office, we have more providers in Oregon than we used to. We're doing a lot better. There's a lot more people who've come forward and said, yes, I'll do this work. But we still need more people. Our population of the trans community is growing. People come here because they know that this is a state that they can access care in. They know that Medicaid covers it. And we need more providers who are doing this work and credentialed with Medicaid.
Can any of you, I know most of you do your work here in the Portland area, but in your backgrounds, can any of you address the rural challenges for trans people in Oregon? It's a huge issue. Erin's taking a big, heavy sigh down there.
Well, I mean, we get down to the fundamental piece of access, and then we get down to some rural cultures, and then we just come down to the people are so very healthcare averse because they've been trained to be by the people around them, by the providers around them, by our social culture and media beyond just the state or the rural area. And so it can be difficult to get past all three of those pieces to try and figure out how you can reach a person, how you can get them into care, and then how you can maintain that care and kind of keep it sustained with providers who are knowledgeable, providers who might stay long enough instead of jumping ship to go to a bigger space or somewhere where it's going to be more affirming. So that's probably one of the biggest challenges, or some of the biggest challenges I see with rural stuff. I know that you do a lot. NEOLA?
Yeah, I think this may sound like a sort of a weird challenge, is that Portland-based folks keep telling your rural-based people that they have to come here, when in reality, we actually have, I feel like, a pretty good number of providers and clinics out in rural spaces. There is a Central Oregon Trans Health Coalition that formed on its own after like a 2-day training, that 100 providers from 3 counties around Bend. I realize there's a lot more than 100 providers in Bend, but that if we keep communicating to people, no, you know what, to get that, you always got to come here. It's bad information, and I think maybe that's actually my answer, is like bad information about what is available to you, and the same thing of turning so deeply inward that you can't go out into the spaces that you actually really need. Yeah.
Do either of you want to add to the rural conversation?
Sure. I actually am brand new to Portland. I moved here about 3 months ago, and I moved from Idaho. Most recently, I was living in Boise, but before that, I was living in a rural town of about 1,000 people in north central Idaho, so I feel like I'm well suited to answer this question. And just speaking from personal experience, when I was living in Boise and working with the queer community while also being queer identified, that was really uncomfortable for me. I wasn't able to have much of a sense of community, and I actually ended up making the decision to leave Boise, which was a really hard decision, just because I recognized how important it was for me to be able to be around queer people that weren't also my clients. So I think kind of having the flight of providers, even though I'm contributing to it, obviously, with my decision to move here, is also a barrier that folks in rural areas face, which is why it's important to really create safe workplaces for LGBTQ folks. Like, I've spoken a lot about patient experiences at PRISM, but I just can't tell you how much it means to work in a place where, as an employee, my identity is affirmed. That's pretty amazing and special, and something I haven't always had.
That's great, thank you. Okay, for our radio audience, this is City Club of Portland's Friday Forum. I'm Lisa Watson, Deputy Director at Our House of Portland. I'm here today with Angela Carter, Co-Director at the EQUI Institute, Danielle Walsh, a professional licensed counselor with PRISM Health, ERIN Waters, Community Health Navigator at KAISER Permanente Northwest, and NEOLA Young from the Gender and Sexual Health Program at Legacy Health. We are now going to go to the audience for some questions. Everyone watching or listening today is welcome to ask a question. If you've written a question on an index card, please hold it up high for City Club staff to collect. You may also submit questions via Twitter using the hashtag FridayForum. To City Club members who'd like to ask a question at the mic, please identify yourself as a member and ask one question in 30 seconds or less. For our first question, we're going to go to Jess Guerrero, a social worker with OHSU's Transgender Health Program. Hi, Jess.
Hi, good afternoon. So grateful for the thoughts that my community partners and co-conspirators offered today. So Nola and Angie, you alluded to this idea of services by and for the community. We're getting ready to launch a community advisory board, and I'm just wondering if some or all of you can comment on the importance of community-led, if not community-centered, care and how each of your organizations are incorporating that model into the care that you provide.
Okay. I am really excited that I get to sit on that community advisory board and help with directing OHSU's policies. I think that having a perspective as someone from community and bringing that perspective to your clients, to your patients, is invaluable because of that mirror, being able to see a lived experience shared by the person that you're sitting with. I'm not saying that this is the only experience that is valuable. Certainly there are valuable experiences with providers who are not of the community, and there can be great rapport and great relationship there. But having someone who really recognizes the impact of what is going on in community, and is keeping up to date on, and that can be someone in or out of community, but is keeping up to date on what is happening publicly, what is happening in policy, what is happening legally, and can stay up to date with those things and advise their patients based on those policies and changes. I think that's incredibly useful. I think that it's empowering for people to see people in their community, in healthcare, in medicine, doing the work. I've had a lot of patients come to me and say, you know, I see the work that you're doing and I want to help too, and I'm going back to school to become a doctor, to become a counselor, because I see the work that you're doing and I see that it's possible. So I think that's another really important aspect of the by and for piece. And in advising larger organizations, I think it's really powerful to have a community advisory board to advise, like, you know, for instance, on surgery outcomes. I know that a lot of organizations collect certain data, but there's patient outcomes that are important to the patients that they want to know about, and so integrating that into what is collected in care is important for continuing the happiness of the patients. What they're looking for in outcomes. For instance, having support in going to offices where you're nervous, which is something that OHSU has done. There's a program that pairs people to go to medical visits and appointments together who are from community. I think that's another really valuable tool to give people the support that they need, and, you know, give someone to debrief with afterwards and talk to about the experience, and you know, avoid the potential of creating more trauma. I'm talking a lot. I can let
That's
somebody.
Great. That's a great answer, though. Thank you. Thank you. All right, next question.
Bill Dickey, City Club member, 60-year-old gay man who basically had to teach himself through reaching out to people what trans was. I mean, because you would think that because I'm part of the LGBTQ community that I would know all about this. I knew nothing. And I think that the problem is bias from way back. And what I want, so to solve that, I think you have to educate people when they're little, so that as they grow up, this is just as normal as black and white, or gay and straight. You just have to teach people about this. And so I'm wondering what is being done about starting trans education in the sexual classes that you start getting in grade school and as it progresses, because education is the way out of this from my mind. But I think there's bigotry involved in this. I think there's as much bigotry in the gay men community as there is in the straight men community about trans people in general. And I just think it's because people don't know what the heck's going on. So I think they have to be educated in order to understand it.
Thank you. Anybody want to address that?
Sure. I don't know that any necessarily of our organizations are in schools, but Oregon is one of the states that has, in our sex education resources, we do have teaching about lesbian, gay, bisexual, transgender, queer. Sometimes the Q is there, sometimes it's not. We have information in some of our sex ed courses, and it is always up to the discretion of parents to say yes to that, which is, that's the rub, is it's there. And also if a parent says, I don't want my kid to hear that, I think that there's some incredible community partners. SMERC has been around the Sexual and Gender Minority Youth Resource Center for over 20 years now. And through their education program, we have similar things like that, who I think have made such great strides to reach out to teachers in schools, to teach out to PFLAG that runs, so many groups for parents, to normalize our existence, that gender variance has existed for all of human history, and that history got erased and rewritten. And I also think that self-determination feels a really scary thing for most people. I think there's my short answer is, I think there's some really incredible work. Yes, I agree with you of how do we normalize from a very young age as part of just our formative years of trans people exist. Sometimes your gender is not what that doctor, nurse, guy on the bus who caught you said it was, right? And that's okay. But yeah, point taken.
Thank you.
Hi, Anthony Petchel, City Club member with Reach Community Development. And thank you for bringing up the social determinants of health. And as we know, most of what happens in our health as humans happens long before we ever step foot inside a doctor's office. So I was wondering if you could dive a little bit deeper into what are some of those barriers that this community faces, and what are things that we can be doing in our community to kind of remove some of those barriers. We're in the housing space, and that is a big impact on people's health, but what are the things that we as a nonprofit should be thinking about as we're approaching our work?
Very simply, we need housing. So, sorry. We talk about this often. We need housing. So if you have houses or buildings or real estate that, most especially, we have had a hugely increasing number of trans and gender diverse people who are houseless due to a variety of reasons. Sometimes people move here for safety and protection, and also some people still get fired from jobs or lose their housing because money is tight or at a loss. So, Reach, CDC, you got some real estate for us. We have some people to put in it.
Well, I'm a community health worker, and so I see these barriers all the time. It is literally my job to help a patient who is struggling with diabetes, who cannot get access to food, and every time they try and go to a food bank, it's a faith-based organization, and they're turned away at the door. And so one of the things that I think is going to be really helpful is as we turn more allies into accomplices, we get people who are going to start pushing their organizations for training. It isn't just a matter of, can I call and say, are you affirming of trans people? Folks will lie to your face. Nobody wants to be the bad guy or the bad person. And so instead it comes down to, what training are you offering? And so even orgs that want to be affirming will say, we don't have any training. We don't actually know what to do. And so there are resources online. There's Fenway, there's University of California, San Francisco. So there are places where you can find this information out. And when you think about healthcare, you have to stop thinking that it's only what happens in an exam room. The example I gave is a good one. A patient who's struggling with diabetes may not have access to food. It might be a financial thing. Maybe they're working 2 jobs. Maybe they're just not sure how to cook very well because that wasn't a skill they got because their parents worked a lot. And so one of the things I do when I talk about this is I encourage people to think sort of like a social worker. You want to look at the problem, and then you want to figure out a million different reasons why it could happen, and then talk to the patient, talk to the person, and let them tell you what they need. Because again, we can only engage with things that are for us if we are helping create them. And so where do you stand? Are you an ally? Where is your organization on training? Where are you on getting out and supporting folks? If your company doesn't have specific information related to supporting sexual gender identity in its non-discrimination clause, you can change that. You can start pushing, you can start making those waves. And so once we start building a better culture, then we are gonna be able to support the trans community a little better, because one of the big hurdles we have is there aren't that many of you. Why do we have to do anything? There aren't that many of you, why do I have to worry about it? We don't say that about any other issue. We don't say that about anything else, that, oh, well, there are too few people for us to serve. It's a concern about the hurdle, the work, the amount of work that's going to be necessary to be affirming. And so we really have to make sure we're taking advantage of those options around employment. Are people getting access to insurance? Food? Are they going to affirming organizations? Even identification. Is your company okay with someone whose presentation may not match their ID until they can get those things changed? And so are you going to be enough of an ally to make sure your human resources department has a plan for that? So those are the things that are going to affect a patient outside the exam room that they're going to bring in.
Thank you. Did you want to add something?
Yeah, absolutely. You know, your question was about resources, and I think resources are obviously so important and something we need more of. But just to kind of echo Erin's point about queer and trans competency, you know, as a mental health professional, if I have someone sitting across from me who's in crisis, I may know of some resources. I may know of a hospital or a clinic I can send them to. But honestly, I really have to think twice with a queer trans person sitting across from me and say, you know, if I send this person to this resource, is this going to make their mental health worse? Because are they going to be misgendered? Are they going to be mistreated? So yes, we need resources, but we need resources that are queer and trans competent.
That's great feedback. Thank you. Okay, next question.
Hi, my name's Annie Tubman. I'm a family doc with Northwest Primary Care. I take care of people with cervixes and people without cervixes. I'm not sure how to say that plurally. What I wanted to touch upon as a primary care doc, I see people of all ages. And I have a large population of LGBT folks and other gender diverse folks. And one group of folks that I feel like I really struggle with finding support for are older adults who, you know, they may be gay, they may be trans, they may be somewhere where they're out or not out. Oftentimes these folks are still leading kind of double lives. And I really struggle with finding resources and support and community for folks where they have that extra isolation, where again, they've lost sometimes their family or community or work support, and now they have a new diagnosis of Alzheimer's or something like that. So I think that's just an issue, and I know that's an upcoming City Club topic, but I was just wondering if you all could touch upon that.
Q Center has a lot of support groups and resources. I would say direct folks, at least for services there. There are trans support groups. There's a women's group, a couple of men's groups. There's Gender Query, which is gender diverse. There's Depression Bipolar Support Alliance that meets there. There's a ton of resources and services there, and there is also Our House, which is a good resource for elder queer folks. And then
Thanks.
yeah. And
SAGE is another program.
SAGE,
Yeah,
yes.
SAGE is another program, and what we're finding is there just aren't that many resources. I actually talk to friends a lot about how we are going to house ourselves as we get older, because there aren't spaces that are specifically affirming or built to be affirming. And when we're talking about our parents or grandparents, we're looking at a culture which was really, really aggressive about oppressing certain identities for a long time. And so even if folks might feel more comfortable being out, it might not be an option for them. And so it's on us to try and find some trees and find some ways to plant some trees that they can sit under. So it's kind of on us to figure out some of these gaps and find some better ways to support folks by engaging with one another around it. So thank you for bringing that question up at all.
And with that call to action, our time is up, and we will have to pause the conversation for now. We are grateful to everyone who made today's forum possible. Thank you to all of our incredible panelists for showing us how our health system can better serve our community, to Lisa for guiding the conversation, to the Pride Foundation and Quest Center for sponsoring today's forum, and to all of you for joining us. Please join me in a round of applause.